teleconference, and we've tended to work in small committees of people volunteering for specific projects. A lot of interest had been expressed in convening a Transgender Women in PrEP committee after this webinar, so we hope there'll be interest in that as well. And if you're interested in that, please contact Anna Forbes, and she gave me her email to share, so I'm sure she won't mind me doing that on this webinar. It's Anna Forbes at earthlink.net, and when we write to all of you after this call, we'll send you that as well. So currently, the U.S. Women in PrEP Working Group is a 4-person convening team, and I must say I am disappointed to not have our convener, Daison, on this call today from Sister Love, who really has had the vision for this group. Myself, Manju Chithani from AVAC, along with Anna Forbes and Deirdre Grant, also from AVAC, are the other coordinators of this group. We've had face-to-face meetings, as I said, and a number of teleconferences. So one of the reasons we have this working group is because when PrEP was being approved as prevention, there was a real need for a national response for women to ensure that PrEP research and rollout addressed women's concerns as well on safety, effectiveness, accessibility, to ensure that as service providers were being engaged and trained, that really issues specific to women were being addressed. I'm hearing some background noise. If whoever has that can mute their line. Thanks so much. We've had meeting with federal officials. We had an official statement, and we've been working with them to respond to that. And the main issue we had was for them to create an ongoing way to address women in PrEP rollout and develop a way for us to engage with the feds on an ongoing basis on this. We've been interacting regularly with them, and most recently we had a report on federal progress at on our agenda at our meeting in February. We're updating our position statement in preparation for expanded dialogue. Our public visibility and impact is growing, and especially needed now as research on women in PrEP is showing us how the social experiences with women are not necessarily the same as men. We're excited to expand our reach. And with that, I am going to introduce you to Sakura. Sakura is all about community healing through art, dance, and self-expression. Currently, she's a researcher at the Howard Brown Health Center, working to expand healthcare praxis that is healing informed, trans competent, and accessible to trans women of color especially. She's returning to Oberlin College in the fall to study public health and Afro-Caribbean spirituality. Thank you so much, Sakura, for leading this call for us, and I'm going to hand it over to you now. Everyone, so sorry for this delay. We've been having some technical issues, and we're having a hard time getting Sakura on the line, and I really hope she joins us really quickly. But in the meantime, I'm actually going to hand over to my, a colleague, Anna Forbes, who's a co-coordinator of this call and has been instrumental in helping to pull this through. And I'm going to ask Anna to get us started and introduce our speakers and get going on the webinar. And I really hope that Sakura can join us at some point. We're trying desperately to get her back. So Anna Forbes, are you there?
And as the Persist Health Project's clinical director, she also focuses on serving people affected by the sex trade. Zil, take it away.
Hello, good afternoon. I hope everybody enjoyed the experimental music piece that we were just performing. So as Anna said, my name is Zil Goldstein. I'm a family nurse practitioner. I prescribe a lot of pre-exposure prophylaxis to lots of different people. And mostly I'm going to be focusing today on transgender women and a lot of the sort of access issues that we face when trying to get healthcare. It's a multifaceted issue, and I'm hoping we can explore a couple of different aspects. I'm just going to wait for a moment until the slides are up on the screen. Great. So, fitting PrEP to at-risk trans people. And, I think it's important to say at-risk people rather than some of the other language that we use that sort of labels people's lives as risky. Like, at-risk populations, things like that. It's really important when we're doing this work to remember that each person that we're seeing is an individual who has different needs. Can we get the next slide, please? I just wanted to talk for a minute about what PrEP is. I have the pleasure of going first in a wonderful lineup of presenters. So let's just talk about what we're going to be talking about. PrEP stands for pre-exposure chemoprophylaxis, or HIV. Basically, when you take Truvada, which is a medication that we do use to treat HIV, when you're HIV negative, taking it every day can dramatically reduce the risk of getting HIV. The medication is referred to as Truvada or tenofovir and ampicillin. The manufacturer is called Gilead. I'm going to be making reference to all of this a little bit later on. So I think that we do, we're here partially because we understand what this is. Again, always good to start with definitions. Can you go to the next slide, please? So moving on in the theme of definitions, I just wanted to make sure we're all working with the same understanding of transgender people. Transgender women are people who are assigned male at birth, meaning they popped out of whatever they were born from, and whoever was presiding over their birth took a look at them and said that they were a boy. Now, transgender women are currently identifying as women. So they decided to disagree with whoever said they were a boy at birth or whoever said we were a boy at birth, and we're now living as women. There's lots of other language that we can use. People don't all the time just transition from one thing to another and stop there. Another thing that you might hear is women of transgender experience, which, oftentimes people will identify as women, not as transgender women. People may have transgender experience and currently identify with the gender they were assigned at birth. This is all very complicated, but we just want to keep in mind that there are certain things that come up for us when we are transitioning our gender. All of the research shows a high degree of health disparities for a variety of reasons among transgender women. We'll get into some of that in a minute. And then I also just wanted to make sure that we are also mentioning transgender men. There's definitely different health issues that can come up for transgender men. Transgender men are less well studied, partially because of a lower incidence of HIV, and historically, all of the money for studying trans people coming from HIV research. So we have a lot less information on transgender men, but there are transgender men out there who are men who have sex with men. And so we have to keep that in mind when working with these people and make sure we're taking good health histories and discussing pre-exposure prophylaxis when it's indicated. Next slide, please. So largely, and like I said, the research on transgender women and HIV is really interesting sort of from a historical perspective. A lot of it is funded by the CDC and NIH through HIV money. But we also, can see from some of the more community-focused research that the picture is fairly complicated. So just to walk you through this slide, 0.6% of the general population is HIV positive. When we look at the entire population of transgender people that we've been able to study, and this is largely through the National Center for Transgender Equality's 2011 Trans Discrimination Survey, and is corroborated in some further work by Lambda Legal and a few other organizations, 3% of the transgender population as a whole is HIV positive. So that's transgender men, transgender women, people who identify a little bit differently, but not as the gender they were assigned at birth. So then, we also, from the NCTE study, can look at numbers of sex workers who are transgender. This is the biggest sample that we have of sex workers, with I think about 700 people identifying as currently doing sex work. We look at 11.8% of cisgender female sex workers internationally having HIV. And again, when we look at all transgender sex workers, we see that that's still higher, 15.3%. And then when we break it down by race, we see a huge jump. So transgender sex workers of color are HIV positive at a rate of about 26%. And then, of the people of color who were responding to this survey, this is still the NCTE 2011 Trans Non-Discrimination Survey, 40.6% of Black and Black multiracial transgender sex workers are HIV positive. When we look at non-sex workers, or the sample as a whole on the NCTE survey, we see that 54.6% of transgender women of color who responded to that survey were HIV positive. Now, there's a lot of different stories we can tell ourselves about why this is the case. I think that, it doesn't take much to see the intersectionality of gender-based and race-based oppression. I just want to say that there's other research out there that shows that there's just the same rate of family acceptance among transgender people of color as there is among white transgender people. So that's usually the first place that we go. We think about transgender women specifically coming out to their families, being rejected by their families, and having some riskier sex based on the options that they have once they've been rejected by their families. But, if we can go to the next slide, please. It's not just a story of family rejection. It's also very blatantly a story of poverty and racism, which, if we can go to the next slide, I believe I have a few statistics on. No, I'm sorry. I think that slide comes a little bit later on. So when we look specifically at accessing healthcare, we see that transgender adults delay care almost twice as much as LGBT adults, and more than twice as much as heterosexual adults. That's for a variety of reasons. Can we go to the next slide, please? One of the things that we see is that transgender people have experiences of discrimination simply accessing healthcare. This is from a Lambda Legal publication from, I believe, 2012, looking at access to healthcare. 65%, over half of the transgender people who responded to the survey have gone into their healthcare provider and said, I need healthcare, and the healthcare provider has said, I don't know how to take care of you. So, if we think about that in the context of PrEP, we're looking at both being transgender as something that many providers are not comfortable with or feel they don't know how to take care of. And then we're also looking at, what is still in lots of places seen as a fringe prevention method for stopping the spread of HIV. So that just gets compounded even further. You have to have a conversation with your healthcare provider about being trans, and then also about the sort of stigma of having, some risks in your life for becoming HIV positive. What's also interesting about this, just focusing more on transgender access to healthcare, is that people get treated differently, people get worse care, and then people, almost 8% of transgender people have been assaulted, physically rough treatment from their medical provider all the way down on the right end of the slide. So this is what we are walking into in the context of using chemoprophylaxis to prevent the spread of HIV among transgender women. Next slide, please. Everything that I've said so far just boils up to the third point on this slide. We as a community do not trust healthcare providers. More of us live in poverty than the general population. More of us are sex workers than the general population. I think this all sort of adds up to the conclusion that, you know, our healthcare delivery system as it exists now does not do a good job of serving the needs of transgender people. And given that we are distributing PrEP through a traditional healthcare delivery system, it's not a surprise that all of the research that we have shows that transgender women don't use PrEP as much, and transgender women don't adhere to taking a pill every day when they're on PrEP. So this is the baseline. This is what we have to work against initially. And then when you think about the number needed to treat being 35, so that means that we have to put 35 people on pre-exposure prophylaxis to prevent one transmission of HIV, which, you know, in my practice, in my experience, is an overestimate. I think that and then the number needed to treat is probably going to be a lot lower once we have more data. It's really important that we get pre-exposure prophylaxis out to communities that need it and communities that want it for stopping the spread of HIV. Next slide, please. So what are we going to do about this? You know, it's very clear that transgender women in particular are very good at coming up with ways to get what we need without accessing traditional systems of care. You know, this slide says underground economies. I don't like that term. I think, you know, community-based distribution systems for hormone care in particular have been very successful. Most of the transgender women that I see in my practice have gotten hormones from places other than a doctor before they come in to see me. It doesn't seem like it would be very hard to increase access to tenofovir and decitabine to those communities, so the people who are selling what we usually refer to as black market hormones can also be giving people black market Truvada. We could also make a pill that says take daily instead of having a pill that says Gilead. And, you know, as a medical institution that relies largely on evidence-based research, we don't have the research that we need to do evidence-based interventions among transgender women. I know that that's a sort of, there's lots of medical complications that could come up, but, you know, there's algorithms for prescribing PrEP. There's people who are prescribing PrEP right now who aren't familiar with Truvada, who are basing their entire practice on the algorithm published by the CDC. So I think that there is an opportunity for what we might call a peer-led intervention that can happen outside of a medical office to get people who need this medication. Next slide, please. No, I'm not going to be able to stay for questions at the end, and I apologize for that. If anybody has questions, they can email me directly at go@persisthealthproject.org. And if you'd like to see some of the references that I was using as my evidence basis for this presentation, please feel free to email me as well. Thank you all so much for your time. I'm so glad you're all coming in.
Well, this is Sakura. Thank you so much for hanging on with us throughout the tough technical difficulty. Next, I'm going to introduce Bob. Active in the fight against HIV since 1993, Bob currently serves as an outreach coordinator for HIV treatment and prevention trials in Cleveland, Ohio. Bob currently serves on several local, national, and international community advisory boards, including community partners. Bob, can you walk us through your data?
Oh, okay, cool. I wasn't sure if I was still on mute. But thank you for this opportunity, and really appreciate it to talk to for a few minutes about community partners and our work to provide transgender inclusion in HIV clinical trials. So next slide, please. Okay, so first I'm going to give you a real brief, I promise brief, tutorial on how HIV clinical research is funded through the National Institutes of Health. So this isn't only going to be helpful for you to understand where I'm coming from, but also will provide you with some important background for our next speaker, Rona Siskind. So first we're going to stop at the top of the slide and work down. So the primary funding institute within the National Institutes of Health is the National Institute of Allergy and Infectious Diseases. And within that institute is the Division of AIDS, and that's what we're really going to be talking about, the Division of AIDS. The Division of AIDS oversees both HIV prevention and treatment clinical trials. And how the Division of AIDS does that is divides up this research into various networks. And each network has a specific focus on what product or what it's trying to advance. So certainly we have the HIV vaccine network, the microbicide network. We have a network that looks specifically at maternal, pediatric, and adolescent trials. There's the HIV prevention trial network and also the AIDS clinical trials group, and the AIDS clinical trials group does treatment trials. So this is the NIH, how it is structured. And then last, but certainly not least, are the clinical trial units, which are where these clinical trials actually happen. And there are actually quite a few within the Division of AIDS. There's approximately 108 clinical trial units and sites, and they're located in 17 countries, so the United States, obviously, but 9 countries in Africa, others in South America, Asia, the Caribbean, and 1 in Europe. And so this is actually an extremely broad network. It's a powerful network, and it's where, like I say, most of our clinical research happens. We're not the CDC, so you'll see CDC funding. That's a separate entity. So, but anyways, so each clinical trial unit, so right here on the ground, can be part of more than one network. So for instance, where I'm at here in Cleveland, we're part of the vaccine and microbicide networks, but we also are part of the AIDS clinical trials group. So you have these sites stretched all around the world. Next slide, please. Okay, great. As many of you know, back in the 1980s and 1990s, AIDS activists in the US and Europe really, it says rallied to reform, but they really fundamentally changed the research process, certainly with HIV, by which researchers and regulatory officials develop new drugs for treatment. Things are much better directly because of their action. And so the result of this has been an inclusion of community in all aspects of HIV-related research and programming through the Division of AIDS. So next slide. So every clinical trial unit is required to have some form of community advisory board. Each one of the networks has a network community advisory board, and these are involved in protocol creation, development, and implementation. And community partners, the group that I'm representing today, is the community advisory to the Division of AIDS, advisory group to the Division of AIDS and to the network leadership. Next slide. So community partners, we've got a very, very broad charge, is we are to promote effective representation of the many communities that surround the sites of our clinical trials units across the Division of AIDS networks. that's huge. Like we are the world. It really is impacts most people in the world. Our topic agenda is also very broad, just looking at that: scientific agendas, ethical conduct of trials, community education, training. So it's very broad, and in some ways that can be a little overwhelming, obviously, but it also provides us a very important tool and provides communities, including the transgender community and people that care about the transgender community, the ability to have a mouthpiece to date. And one of that would be community partners. And that is part of our charge, is what is the community saying? What are they wanting? Next slide. As part of our carrying out this duty, last year, community partners sent recommendations on transgender inclusion to the Division of AIDS and Network Leadership. We first did recognize that many of the networks and communities, and including the Division of AIDS, recognize the transgender community as being underserved and supported efforts to do better by it. Our memo, which was just a simple 2-page memo, we wanted to keep it short and to the point. We did recognize that in implementing anything, that the first rule is to do no harm, that transgender people face very real and very severe physical, psychological, social, and legal harms. And so that everything we say should be interpreted in light of the safety of individuals. Next slide. We made 4 general recommendations. 1, to presumptively and affirmatively include transgender people in all of our protocols. This would require protocol teams to address the issue of transgender inclusion early in the protocol development process, not as an afterthought. And that if a protocol lists a gender of any type, male, female, then it should also affirmatively include transgender people. These many sites and many communities need training and resources to properly provide good service to transgender people. And also, local connections at the site level needs to be made to local transgender people and organizations. Data collection. There should be a uniform data collection tool providing all people the ability to fully describe their gender. And it also needs to be done in a manner which permits cross-network analysis of trial participation and results. As most people probably know, a lot of trials happen, and just the numbers of transgender people in a specific trial might be so low that we're not being able to draw very good conclusions. So we need to start a uniform data collection, and finally support researchers investigating transgender unique issues. And I think Dr. Goldstein really certainly laid out a lot of them, but I'm sure we could all come up with our own list. Okay, next slide. Rona Siskin is actually going to be providing the DAID's response to our recommendations. I did want to just briefly say that there is an organization, HANK, which the slide has its website up there, which provides support to community partners. And so information about community partners is right there. And next slide. And this is some of the work that we do, recommendations for community engagement in HIV/AIDS research. I know this is an update done last year. A lot of people put a lot of work into this. Now it's important for us to follow it. And last slide, next slide. We welcome feedback. One of our jobs is to hear from the community and pass that on. Russell Campbell is provides us support, and that's my email address down there. So thank you very much for the opportunity.
Thank you so much for that poignant data. Now I'd like to introduce Rona Siskin, Rona Siskan has worked with the Division of AIDS at NIAID for over 20 years. Committed to community engagement and research, she serves as the liaison to community partners and conveys the cross-network transgender working group. Rona, thank you so much for joining us today.
And then the next one, please. So the Division of AIDS formed the Cross-Network Transgender Working Group in response to that memo that Bob described from community partners. And it includes representatives from each of our clinical trials networks, as well as representatives from community partners, from HANC, the Office of HIV/AIDS Network Coordination, several staff from the Division of AIDS, and several transgender men and women. The working group hopes to address many of the issues raised by community partners to better facilitate inclusion of transgender individuals into all of our network trials. The group is currently discussing research opportunities and continues to identify and share resources and ideas with one another. Next slide, please. To date, the working group has developed and advocated for the use of a common template for data collection using the two-step approach, which separates gender identity from sex at birth. The group is now reviewing and compiling training resources and materials, advocating for increased enrollment of transgender men and women in trials as appropriate. Next slide. So I wanted to just take a minute to show you the data collection template that the group recommended. It's based on current best practices, which treat gender identity and sex at birth as two independent variables. This is the first question asking about gender identity. And you can see that there are a number of options that people can identify with or add in whatever terminology they prefer. Next slide. So the next question asks about sex at birth, which is more straightforward, and it's followed by a question about sexual orientation, again, for which there are a number of available terms or an option for additional ones to be written in. Several of our networks are already moving toward use of this forum, and we're encouraging all of them to use it, even when trials don't specifically target transgender individuals. Transgender people may be eligible and willing to participate in a trial, and even if they're not specifically targeted, this would make the data collection forums more inclusive and the experience much more welcoming for them. And of course, it would more accurately capture the data. Next slide. I did want to mention some of our related network activities that are separate from the working group. The HIV Prevention Trials Network, or the HPTN, for example, just held a workshop on HIV prevention for transgender men and women and other gender nonconforming individuals. Because there's the high burden of HIV in the transgender community, which you've already heard about, but little HIV prevention research focused specifically on that population, the workshop was held to review what's currently known, to hear from several people in the transgender community, and to discuss possible research opportunities for the HPTN. In his meeting summary, Dr. Ken Mayer emphasized the need to ensure the appropriate of data collection forms, which is basically what I just shared with you, the need to include transgender people on community advisory boards and the network's community working group so that they have research into the research studies that are being developed, and there's a need also to conduct trainings for all staff to ensure cultural competency so that transgender people feel welcome and comfortable even when they enter the clinic. Dr. Mayer also noted the need to increase enrollment of transgender people in large efficacy studies, which I'll talk about in a minute, and he identified some possible studies for consideration based on research needs that were raised during the meeting. Next slide, please. Although a number of HPTN studies and other NIAID-funded studies on PrEP have included transgender women, the numbers of transgender women, particularly that have enrolled, have been relatively low. There are, however, 2 studies currently in development that are purposefully including transgender women, and I thought you'd be interested in just hearing briefly about them. The first study is known as HPTN 081, but it's being conducted jointly with the HIV Vaccine Trials Network, or HVTN, so it's also known as HVTN 703. And this study will look at the safety and efficacy of a vaccine using a broadly neutralizing monoclonal antibody to reduce HIV acquisition. The study will enroll about 3,900 volunteers, including transgender men, transgender women, men who have sex with men or MSM, and at-risk women. Both the HPTN and HVTN are working with community groups to provide education and information to stakeholders, and will be conducting consultations to help the research team better understand community questions and concerns. They'll also be developing transgender-specific materials for outreach and recruitment, and will be conducting many staff trainings. HPTN 083 is looking at a long-acting injectable form of PrEP using cabotegravir, and they'll be comparing that to daily oral Truvada. The study will be enrolling about 4,500 HIV uninfected men and transgender women who have sex with men. And again, because the study will intentionally be enrolling transgender women, there will be cultural competency training for staff and outreach and educational materials specifically targeting transgender women. Next slide, please. The HVTN has also been working to be more inclusive of transgender people for a long time. They established a transgender working group in 2007, and early on they reviewed demographic data from 6 of their phase 1 and phase 2A studies to get a better sense of transgender people as low-risk trial participants. While there were only about 14 transgender participants in those 6 studies, they did come away with a great deal of information characterizing those participants, and found overall that they made very good volunteers for those types of studies. HVTN 505, which was a prime boost vaccine study, was the first vaccine study to specifically name transgender women as an eligible population, distinct from MSM. And during that study, the VTN conducted several focus groups in 4 cities and surveyed a small number of current and previously enrolled transgender trial participants to assess their experience and obtain information that would help guide future outreach efforts and trial design. Next slide, please. So while I can't go into great detail, I did want to share with you some of the barriers and facilitators that were identified. I've combined here what was learned from both the focus groups and the surveys. And among the barriers noted were stigma and marginalization, a general lack of information about what research was going on, or not even knowing that they might be eligible for some studies. General mistrust of the scientific community and discomfort associated with simply walking into a clinic were also identified as other reasons transgender people might not want to join the study. Next slide, please. Whoops, I'm sorry. While there were only 11 individuals, transgender participants, who completed the survey, they were overall very positive about their experience, and they described it as either great or wonderful. Even so, between the focus groups and the surveys, there were a number of factors identified that would make research more culturally sensitive and respectful. I'll just note a few from this list, including the need for sites to develop relationships with providers and organizations working in the transgender community to ensure that they're aware of and receive information about planned or ongoing research, the need for staff training, and the importance of a transgender-friendly environment, which might include gender-neutral bathrooms, a welcoming front desk, or inclusive materials in the waiting rooms. Next slide, please. So the HVTN has implemented a lot of changes, and in addition to staff trainings, they continue to develop partnerships with community organizations that are transgender serving, and they've also already moved toward the use of the 2-step approach for data collection. They've also revised protocol language around the requirements for pregnancy testing so that it's more appropriate for transgender participants, and have created recruitment ads featuring transgender women, among other things. The lessons learned from HVTN 505, the focus groups, and their surveys will all be incorporated into the outreach efforts and the conduct of HVTN 703, which I've already discussed. Next slide, please. The last network that I'll highlight briefly is the Microbicide Trials Network, or the MTN, which has also held transgender consultations in relation to rectal microbicide research. The first consultation was in 2013 and had a diverse group of transgender men and women with different levels of knowledge about HIV prevention research. The goal was to provide an overview of rectal microbicides and to increase awareness and support for it, and also to provide a forum for discussion. In terms of takeaways, the participants felt that there are not enough studies for transgender people, and that transgender women overall should not be lumped together with MSM. They wanted to be able to identify as they saw themselves and express fears around participation related to not knowing the outcome or impact of a medication. They wanted to be included in discussions about trial design and greatly appreciated the opportunity for direct information and input. Next slide, please. MTN 017 was the first phase 2 study of a rectal microbicide evaluating the safety and acceptability of tenofovir gel. The study successfully enrolled transgender women with about 12% of participants identifying as such. The majority of them were enrolled in the Chiang Mai site in Thailand. It's been completed and the study results are expected in early 2016. To determine the next steps, the MTN has been holding a number of consultations which have led so far to the decision to conduct a smaller phase 2A study rather than a phase 3 study. This is due to a number of issues, including acceptability of the applicator used to deliver the gel. Additional studies, such as the Adonis study, will also be pursued to examine alternative delivery approaches. And the MTN maintains a very strong commitment to the inclusion of transgender participants in all of its future studies. Next slide. Thank you. So I'll really just stop there and want to thank the Cross-Network Transgender Working Group and all the staff at the different networks and staff at DAIDS that provided information. I did not put my email up, but I'm happy to take any questions via email, and I'm sure the facilitators of the webinar can provide that. Thank you.
Thank you so much. We really appreciated hearing that. Now I have the pleasure of introducing Cecilia. Originally from Argentina, Cecilia Jungentheim is an advocate for trans rights in New York City. Currently, she serves as the Trans Health Coordinator for the APICHA Community Health Center. She is a contributor to Trans Bodies, Trans Self, and is a board member at PrEP Health. Thank you so much, Cecilia, for joining us today. Can you please walk us through what you have to present for us? Thank you.
Thank you. Thank you so much. I hope everybody can hear me. Wow, I look amazing in that picture. Thank you. I wanted to say before I start that I'm going to be talking for myself as a community organizer, not for any, or in behalf of any organization that I belong to. So if we can go to the first slide, please. This is a quote that I got from Marcela Romero, who's the coordinator from Red Like Trans, Latin American Caribbean Transgender Network. And she said something that struck me, and she said, I am not a high-risk person. I am a member of a community that is put at high risk. And I felt like that was important to make a note during this webinar. If we can go to the next one, please. Transgender people often face high levels of stigma and discrimination. We can say that agencies and medical providers have usually a tendency to associate transgender folks and transgender women of color, especially, with HIV and nothing else. So what I'm trying to say here is that sometimes transgender people have many other problems but HIV. So it is sometimes problematic for, for example, for me as a transgender woman of color, when I am seen only as a part of this HIV problem. Because this perpetuates the stigma and the idea of transgender woman of color as a factor of spread of HIV, which leads us, trans people and trans women of color, sometimes to not want to be a part of any campaign. Can we go to the next slide? HIV prevention initiatives led by transgender people are the most effective. It is proven that all kind of initiatives related with HIV prevention work the best when they are led by transgender people. But what happens? most of the time we see cisgender folks doing that work. We see cisgender people that do care for the community, but they see cisgender people doing this work of HIV prevention. And sometimes this work is a factor in making trans people feel less about themselves and as a community and individually. If we can go to the next slide. Generalizations about the sexual behavior of transgender community and people exist, which can impact upon the effectiveness of HIV prevention and intervention. This is what I'm going to talk about a little bit later when I'm going to talk about my personal experience by going to a medical provider and being seen just as a factor of HIV spread. If we can go to the next one. During many encounters with medical providers, I was directed to the HIV talk without even evaluating my risk. I happened to, I had to go to the emergency room a couple of times, and instead of being evaluated for whatever my problem was at a time, I was given the HIV talk, when in reality, I didn't go there for that. And I think it's very helpful if we try to link every kind of situation to, prevention. But if you focus only your interest on HIV, me as a transgender woman of color, it made me feel a little bit like you are kind of targeting me in a not very, very good way. I got assumptions about my sexual life, because I am a transgender woman of color, I faced, all these medical providers assuming that my sexual risk was other than what it really is. And that led me to never coming back to those providers, which perpetuates the idea of transgender people, transgender women, of course, especially not wanting to go to see providers. If we can go to the next slide. I believe that we can work around PrEP, and by leading this work with the same population that you're trying to work for. What I'm saying is, let's use transgender people, and if you want to work with transgender women, let transgender women work for them, and it is proven to be a much more successful rate of success when you have trans people working for trans people. I think it's also important to associate PrEP with the real needs of the community. People are going to be more receptive to PrEP as prevention if you are linking these kind of campaigns with the real problems that the community face that are, not being able to go into the workforce, accessing medical services, and doing some work around violence and discrimination. With all that, I think that's all. Thank you so much for the opportunity, and I hope everybody enjoy the rest of the day.
Thank you so much for that research. I really enjoyed hearing all you had to say. That was such a great presentation. Next, I have the pleasure of introducing Prudence. Prue Mendola is a counselor and a research assistant at Friends Research Institute. She has been doing HIV prevention for at-risk populations for the past 5 years and is currently working on research projects to help create evidence-based interventions for transgender women. Prue, can you take it away, please? Thank you so much for joining us. Prue? Are you on the line with us? I'm sorry, please hold with us while we're experiencing this technical difficulty. Thank you all for holding. Prue got disconnected and she's redialing in as we speak, so we'll get on as soon as she's as soon as she gets back connected with us. While we're waiting for Prue to join us, I'm going to go through some questions real quick. One question that popped up is, what is the commitment of AMP study, the HPT in 703, to including enough transgender people to have the power to analyze them as a subgroup in terms of research questions? Will certain sites focus specifically on trans men and trans women recruitment? And that question will be directed for Rona. Could you take it away really quickly for us?
Hi, this is Rona. Thank you. I think that let me just grab my notes. I can't tell you exactly how many transgender men and women will be enrolled, but I do believe that they are looking to have enough so that the data would be analyzable, but I'm not sure I have a specific number or that that's been determined yet. In terms of sites, I think the study is being conducted in North and South America, as well as in Africa, or am I confusing that with 083? I'm asking a colleague who's sitting here with me. I think that's 083. So I'm not sure I can answer that, but I can get the information and send it to you. I believe that some of the sites will focus at-risk women, and others will focus on transgender men, women, and men who have sex with men. But I'm not sure I can tell you specifically where all of those sites are.
Thank you so much for that question. We're still awaiting Prue to get dialed in. I also want to make a quick note. If anyone has any questions currently to ask any of our panelists, feel free to type those in right now, and I will read them out and ask them to the appropriate panelist. Well, we're still waiting for Prue to get connected. My lovely coworker Cassie is going to talk a little bit about an affinity group that we're working on specifically for trans.
Hello?
Oh,
Prue? Prue?
Yes. Can you guys hear me?
Hi. Thank you so much for joining us.
Hi.
Um,
I'm so sorry. I've had so much technical difficulty on my end.
No worries. Thank you so much for joining us. I just want to let everyone know that this panelist is going to be more of an interview style. I want to ask her a couple of questions about her experience using PrEP and her experience working with the community. So I guess with that said, I'll start off with the first question. Prue, can you tell us how you first learned about PrEP?
Well, I first heard about PrEP because actually I was asked to join a community advisory board for some research projects that we're launching here in Los Angeles. At the time, I was working as the chair of the Transgender Service Providers Network, which is a network we have here that all service providers that provide services to trans women join, most I should say. And so I joined them through my agency, which is Friends Research Institute. And because I was leading that up at the time, they wanted to make sure that the trans community had a voice in speaking about what was going on in PrEP. So I joined the Community Advisory Board initially because of that and my experience as a counselor and tester for HIV. And that's when I began to learn about it. You know, we were launching these research studies, and I was actually surprised that I hadn't heard anything about it before that. But that sort of sums up how I learned about PrEP.
Well, thank you so much. When did you start to think about PrEP and how it might be useful in your own life? Sort of your response, multiple appointments, co-pays, and any important details you want to talk about that experience.
Yeah, so basically it started out because we were putting together a forum for the transgender community to sort of spread the word about PrEP and things. And we had a really, really hard time finding trans women who had ever used PrEP or even heard about it a lot of the time. And so I thought, okay, well, I'm a trans woman, so why don't I think about doing this? That way I'm able to do these panels myself. And so it was really mostly a professional decision, but after the fact, after I decided that, it became a little bit more serious to me because I had divorced my husband at the time, and I had gotten to this point where I had begun dating again. And I thought, you know what, maybe it would be a good personal decision as well.
Oh, okay, great. That makes a lot of sense to me, and I definitely can relate to that on numerous levels. What are some of the other reactions or some reactions you get when you talk to other folks and people about your own decision to use PrEP as a trans woman?
Originally, when I had first decided to use it, I got some reactions that were pretty negative. You know, there was some negative ideas around PrEP and that, you know, anyone who's taking PrEP is just using it as an excuse to be riskier, if you will. And so I literally had people that are extremely educated in the community asking me, like, why? Are you just going to stop using condoms? And my response to that was like, you know what? First of all, it's none of your business what I do in my bedroom. This is work, and that's my personal life, you know, and I tend to keep them separate. But secondly, it has no bearing on that. It's just another tool that I would like to use to, you know, to keep myself safe.
Wow, that makes a lot of sense to me. I never thought about specifically how some coworkers and partners that we work with and see on a daily basis and how their own sort of internalized struggles about using PrEP might affect our own personal decisions. From your perspective, what are the next steps you think need to happen in rolling out PrEP to women in our community and dealing with some of that sort of imposed transphobia on the community, specifically around using PrEP?
Yeah. Well, you know what's interesting is I'm conducting a lot of surveys right now for a research project we're doing at my agency, and I'm still surprised at the amount of trans women that are very active in the community, and you know some of our clients and things that we educate ourselves that still don't know about PrEP. And I have people asking me, well, what's PrEP? And I'm like, I almost want to fall off my chair when I hear that. So, you know, there's clearly still a lot of educating the community that we need to do, but I think more than that, because technically insurance should be covering PrEP, and especially like Medi-Cal, Medicaid, for example, should be covering it. And a lot of the problem is with providers that just don't know what it is or are unwilling to provide it or write a prescription for it because they just don't know about it. And so I think that one of the major next steps is really reaching out to as many providers as we can and, spreading the word about it, because this is a great tool in prevention.
Wow, that's such an impactful experience. I think it means so much in our work. I'd like to thank you so much for coming and talking with us today and being a part of the panelists. And I'd like to also reach out that gratitude to all the panelists that are able to join us today. And I also would like to invite everyone who's listening in to type any questions that we can answer currently at this time. And I think we have one right now that just popped in. So one question is, why isn't the federal government running PSAs on TV about PrEP, especially for women? It seems like there isn't any sort of like publications out there that are reaching the community, and tying that with Prue's last statement about sort of community education. So Prue, would you like to talk a little bit more about some of the publications, and if anyone else wants to take that question on?
Oh, well, I can't tell you why the government does or doesn't do anything, but I can tell you that that would be a great idea. And we are definitely doing some work on making it more sort of visible to the public, if you will. We're putting on some campaigns right now. I'm going to be presenting at the United States Council of AIDS in September, and I've been working with them to sort of make it a little bit more visible and accessible to the community. It's difficult because a lot of what we do goes up online, and it's not something that you're going to just drive by on your way to work and see, or see a commercial for while you're watching TV. And I really think that that's a great sort of idea.
Thank you so much. I think that's a great idea as well. Prue, do you mind talking just a little bit more about why are ways to solve the sort of lack of knowledge or lack of experience in using PrEP and treating PrEP with patients that medical providers are experiencing in that inter-exchange? And why do you think medical providers have such a hard time sort of swallowing in a way the information of PrEP and its usage for the community?
Mm-hmm. I think a lot of providers are just unknowledgeable in general about transgender issues, and what happens a lot of the times is that they are liable for what they do, and I think they're just afraid more than anything else because they don't know much about it, and so they're unwilling to prescribe something that they don't have all the information on. And what's really interesting is that the information is out there. You can access it on the CDC's public website, on local agencies, and they have this information. It's so at your fingertips, and it's just ridiculous to me. But what we do a lot of the times is we have some flyers and pamphlets that we distribute to providers and that we give to our clients when they're interested in starting PrEP. We're like, okay, here's some information for your provider. If they have any questions that can't be answered here, have them give me a call, and I will be happy to answer these questions for them.
Thank you so much. The next question goes to Bob and Rona. What would Bob and Rona suggest that people on this call should do if they want to see more public investment in making PrEP available for women? Bob and Rona, do you want to answer that question?
Hi, this is Bob. It is a little outside of my expertise, as that is obviously an extremely important piece of information, which is like implementation. But one of the things that you actually might, and there's many things, one on a state level, but certainly in terms of a thing called implementation science research, where and there's some pilot programs that look at that, is really encourage just some of the wonderful things that we heard from our presenters here about accessing PrEP. If those things can be done in a sort of a research modality, like follow up with people, what is their experience, that type of thing, I think that goes a long way in moving like care and treatment forward, and certainly prevention. So I would say really press the research organizations and agencies to come up with everything that they can to find out what the real barriers are in real world getting PrEP out to people, which is sort of different than a clinical trial. Everything's very structured, but that real world, some of the information we heard today was excellent in terms of that, but put down where scientists and researchers can apply it. That would be my response.
Rona, would you like to comment on that question? Another question we have is, has there been research currently done on feminizing hormones and PrEP usage? If so, what does that look like? And if not, will that be done in the future? And if Bob or Rona want to take that question as well, or any of our other panelists who are still available to comment on that, you can take that question away.
I can speak to that. This is Prue. So currently there are no known hormone interactions with PrEP. However, there is going to be some research in the following years that are going to be conducted in a lot of agencies, especially in Los Angeles right now. And so we are going to be conducting that research. But as it stands with our current research, there hasn't been any known side effects. There hasn't been anything showing up between hormones and the PrEP, and it doesn't look like there's going to be. But we are going to be conducting extensive research to see if there's anything that does happen. And I feel like a little bit of a guinea pig sometimes, but I feel like we won't really know for a long while if there's anything long term, but as it stands, it doesn't seem like there is any interactions whatsoever.
We're waiting for some other questions, and I'm going to have Cassie just talk a little bit about the affinity group for trans folk.
Hi, everyone. Good afternoon. My name is Cassie, and I work with the lovely Sakura. And I've also done work with the U.S. and PrEP working group, and one of the things that came out of organizing this webinar was to try to create some ways to develop more trans leadership, specifically that features trans women. So we're hoping, we want to put out there that the U.S. Women in PrEP working group wants to support an affinity group. So if there are trans folks who are still on the line and listening and you want to send us your emails, we'd be happy to connect with you and get you connected. Don't really have more information about what the affinity group would look like because that would be determined by the folks who want to be in the affinity group. You should be able to just type into the chat box your email and we'll be able to follow up with you. If not, you can always email me directly at cassiew@howardbrown.org, and I can type that into the text box for you all. Thank you.
We have another question about PrEP and how to pay for PrEP. So it says, can someone talk a little bit more about PrEP? Is it covered under Medicaid? Is it covered under insurance? And if so, how do folks go about accessing that? And I think, Prue, can you talk a little bit more about that or any other available panelists?
Yes, I can speak a little bit about that. So Medicaid and Medi-Cal should cover it. It is covered under those plans. However, a lot of the times people are having difficulties in the actual feasibility of doing that, but it's supposed to be covered. So if you are on Medi-Cal or Medicaid, you are covered for PrEP. It's just when you actually put that in practice, you can encounter some barriers in that. Through Kaiser, it's covered as well. There's a $48 copay for the prescription. However, Kaiser also has medical financial assistance for those that qualify. That'll cover your copays for prescriptions. And if you're in higher level tiers, you will be covered. The problem comes in when you have a bronze or silver tiered plan. The copays are just through the roof, anywhere between $500 to a couple $1,000 sometimes. So that can be really difficult because obviously if you're paying for a lower level tier, it's because you're on a certain budget. And it's really difficult when you're in that sort of medium range to get covered for PrEP.
Thank you so much. Another question is, is there an interaction with PrEP and other drugs, particularly ones accessed by the community through the street? So if someone is using, for example, heroin or crack or some other drug, does it affect with PrEP? And if so, what would that effect look like?
So if I could speak to that as well. Basically, if you think about it in the sense that PrEP is pretty much HIV medication, and there isn't a lot of research that shows many interactions, and basically you're not going to deny someone HIV treatment if they are a substance user. The same thing goes for PrEP. There hasn't been a lot of research done necessarily, but as what it stands now with what we have, there isn't any interaction from what we can tell so far.
Thank you so much, Prue, and every other panelist that was able to join us today. And thank you all for typing your questions. We really appreciate everyone's insight and availability. Now I'd like to hand it over to Manjeet to talk a little bit about our working groups and events coming up and for our close. Thank you all so much.
You're welcome.
Thank you very, very much. This is Manjeet Shithani. This has been a fabulous almost hour and a half that we have spent together. And again, I excuse us for the technical difficulties we had at the start, but I think you'd agree that we've had some fantastic speakers and great questions. And I'm sure this is only the beginning of the kind of questions you all have, and want to encourage you to send those questions in and for us to continue this dialogue. And one way to continue this dialogue is a Transgender Women in PrEP committee that many have shared and have expressed an interest in putting together. And I'm going to suggest that we write to Anna Forbes, who is putting together the names of people interested, and we'll talk a little bit more about what this group committee could possibly do. And Anna's email address is annaforbes@earthlink.net. That's ANNAFORBES @earthlink.net. And she is going to put together the names and let us know how many people have been interested and move it forward. I mean, I think that the one thing this call has especially done is let us know that this isn't the beginning of a discussion. This discussion has been going on and in very real ways happening through implementation and research, and that a consolidated effort to respond to it could only benefit all of us who are interested in working in this issue. And I hope this committee is one way to do that. I'd also like to encourage all of you who are interested in this broader issue of women in PrEP in the US and ensuring that the issues and the concerns and the opportunities we address are brought together, and that we connect the dots better, and encourage all of you and invite all of you to join the US Women in PrEP working group if you're interested. And with that, again, I want to thank Sikora for leading us through this fantastic discussion. I want to thank all the presenters and my co-coordinators and the convener, and to all of you, over 300 of you who joined this call to listen and participate. And thank you again, and have a lovely rest of the short week you have and weekend. So thank you again. And thank you to Laurel Mustafa, I must say, for dealing with all the technical stuff and putting this call together. It's hard to put so many people on a call, and I give her credit, and thank you very much as well, Laurel. So with that, thanking you all, and have a lovely rest of your day.